continuing on with some points from the medical history and exam for the pulmonary system. We had mentioned looking at auscultation, listening to lung sounds. So to kind of understand, not only can you actually hear lung sounds or notice that they're absent, to hear what's considered normal and abnormal. So your normal lung sounds that we have are your tracheal, bronchial, vesicular, and bronchovesicular. And those areas are noted if you look at the picture, and you have the same picture in your text. So those are kind of like the normal lung sounds for those various areas. Obviously, if you were to hear them outside of those areas, that would be considered abnormal as well as some of the other abnormal sounds that we're going to listen to. But when they're heard in those regions, those are kind of normal lung sounds that you'd be looking to hear. And just, some descriptors, and these are also in your textbook as well. The tracheal and bronchial sounds, they say, sound like a wind kind of getting blown through a tube, and the expiration is the louder portion of that. On the contrary to that, vesicular sounds are louder on the inspiratory, and the kind of the comparison they look at there is what they call rustling leaves. So if you go outside and hear leaves blowing around in the wind, that's what they kind of compare that to. And then the bronchovesicular, it's a combination of sounds, so they sound more like vesicular sounds during inspiration and more like bronchial sounds during expiration. So those are your normal lung sounds, again, that you want to hear within those confined areas. Now we get into some other things, some abnormal things that you would hear. Bronchophony, whispered pectoriliquy, and egophony. So those are all abnormal things. So bronchophony is being able to hear spoken sounds through the lungs as somebody is, as you're listening. Whispered pectoriliquy is being able to hear whispered sounds, and egophony are high-pitched spoken sounds. Again, those are all kind of abnormal things you'll typically hear when the lungs are inflamed. So if there's inflammation of the lungs, you will hear that. Some of your other abnormal sounds that you'll hear, Rales rhonchi, stridor, and pulmonary friction rub, are different types of again, abnormal sounds. Rales kind of sound like popping and cracking as the individual is breathing. Rhonchi are rumbling sounds that you'll hear on both inspiration and expiration. Stridor is a very harsh, raspy type of sound, and that's actually a medical emergency. And we'll kind of see what some of these come out as when we look at some of the different conditions. And then pulmonary friction rub is another thing that kind of illustrates that there's some type of inflammation in the lungs as well. So any of these are basically, again, abnormal sounds that you would hear. Obviously, again, too, you're listening just to hear lung sounds, so you have to note if you either hear absent or decreased sounds as well. So other things you want to make note in a pulmonary exam: the respiration rate and depth. So know and understand what is considered normal breathing for both adults and children. So adults, you're looking at about 12 to 20 breaths per minute. And again, note also the quality of the breath. So again, under normal resting conditions, it should be relatively effortless. Obviously, if you're just examining, if you're covering an athletics event, obviously their rate and depth could be altered by the fact that they're also in the middle of activity. So you have to kind of be mindful of that as you're kind of noting this, as you're doing this. For children, adolescents, you're looking at a obviously increased rate. They usually say 12 up to 30 breaths per minute would occur with children and adolescents. Hyperpnea is an increased rate or depth of breathing, so you'd want to note that as well. That which is different. Now that's different from hyperventilation. Okay, so when you increase the breathing rate without increasing depth, that's hyperventilation. So basically hyperpnea, you increase the breathing rate or the depth. whereas hyperventilation is increasing the rate without an increase in depth. So it's important to note the difference between those two because you're going to treat them differently. Obviously, there's a connection between heart rate and blood pressure. We had note that's going to be important to note that as a component of the exam. So heart rate and respiration rate both go up together. So it's important to kind of note that, and also to kind of note the relationship with blood pressure. So as the amount of oxygen in the blood decreases, the blood pressure will increase. So you could kind of see how those two things relate, and important to note. A peak flow meter, which we'll talk about in the management of asthma. Okay, so you want a peak expiratory flow and kind of note. So in patients that have asthma, they will kind of set a personal best through their physician as far as what they can reach with this. And what they look to find is that when you have an asthma patient, you take the peak expiratory flow. If it's less than 80%, it indicates that there's a chance that they could possibly have an asthma attack. So that would be a situation where prior to a practice or a game, you'd want to make note of their peak expiratory flow. Less than 80% indicates a possible attack. If it's below 50, that's at the point where they're probably in some sort of distress and will likely need to be transferred to a hospital. Your pulse ox measurements, you can see the pulse ox meter on the picture on the screen. And what that notes is basically the oxygen saturation in the blood. So it kind of lets you know how much oxygen. It's basically the percentage of the hemoglobin that actually contains oxygen. So hemoglobin's that component of your blood that carries oxygen. We look to have a greater than 95%. If it's less than 92, that usually tells you that you need some sort of supplemental oxygen, which is what we'll be talking about next. So again, here we're just looking more at respiration. We notice our normal rate of respiration in adults. I believe on the notes on the slides you might have 10 to 15. Again, we're kind of looking within the same range there. The textbook in this chapter does say 12 to 20. Again, you kind of have an idea within those ranges. You're fine. Here we're noting what we had talked about before. Over 20 breaths per minute, increased depth, hyperpnea. So again, to differentiate between hyperpnea and hyperventilation. So hyperpnea, you get an increased rate or depth, and that's caused by low oxygen levels. So the other important thing to note is what's causing each one of those, whereas hyperventilation is actually caused by a decrease in carbon dioxide. So, again, it's important to differentiate between these two because the treatment is a lot different for one versus the other. Hyperpnea is actually a medical emergency, whereas hyperventilation is not. Obviously you want to look at your other signs and symptoms and why they'd be having one versus the other, but you'd want to know. Now what you can actually do is, if the situation allows for it, have the individual hold their breath briefly. If they hold their breath and they don't get better, then you're looking at hyperpnea and you have some type of decrease in oxygen. Whereas with hyperventilation, by holding their breath, it'll actually improve, because what will happen is their carbon dioxide levels will actually increase because of holding their breath. So, when you look at just something, whatever that would trigger the hyperventilation, you can usually solve that pretty easily by doing that. Obviously, again, you have to look at the rest of your exam and why that would be happening, and as far as determining, whether it'd have to be referred or not. But simple hyperventilation can usually be treated relatively easily, just by getting them to control their breathing a little bit more. So again, understand what causes the two of those, and also then understand kind of the differences in the treatment and kind of what the initial management for those are. So this takes us to looking at interventions for pulmonary conditions, particularly as they relate to more, urgent or on-field, if you will, situations. The first thing is to look at supplemental oxygen, which is something that had been discussed in emergency response, and just to kind of look at how we kind of give supplemental oxygen. The two different tank sizes that are typically used in the athletic training setting. You have a 360 liter and a 625 liter. You have your regulator, which contains the different components of the oxygen tank to help kind of adjust the flow of oxygen. And then we look at the different delivery devices which we have. And they all just basically give different percentages of oxygen and different rates of flow of oxygen. So the three that you have the nasal cannula, the non-rebreather mask, and the bag valve mask. As far as your delivery device is concerned, again, giving different percentages of oxygen in differing amounts. So the nasal cannula, for instance, gives the lowest amount at 25 to 40% at about 2 to 6 liters per minute. The non-rebreather gives 60 to 90% at 10 to 15 liters per minute, and the bag valve mask is about 100%, so it's the highest concentration of oxygen. So those are the different delivery devices you would use. Just in as far as procedurally on table 7.4 in your textbook, it kind of goes through the procedures, so just kind of be aware of that. One of the things to note is just to make sure that whatever device you're using, remove that device before you turn off the oxygen. And this is just these are just illustrations, just kind of showing you the nasal cannula on the left and the non-rebreather mask on the right. Again, it's just going to be based upon the amount of oxygen you're looking to deliver to the patient. Here are some illustrations of some other interventions, and what we see here are particular interventions as they relate to asthma, which we're going to spend a pretty good amount of time on talking about in this chapter. Obviously, with physically active people, asthma is a pretty big concern, and in particular to the typical population we normally work with in our athletic training settings. So here you have a couple different pictures. You have a picture of a meter-dosed inhaler, which is the emergency inhaler we commonly think about that contains a beta-2 agonist drug, which is a bronchodilator. So those are your emergency inhalers. If you look in the upper right-hand corner, and then you also see one with a spacer attached, which is actually a recommended way to deliver the medication. Again, remember, the key is this medication has to get to the lungs. So a lot of times when patients use meter-dosed inhalers to deliver the beta-2 agonist, if they don't use a spacer, a lot of the medication tends to, more or less get stuck in the mouth, and we want the aerosol to actually get to the lungs. So the spacer, if you see on the picture on the left, the larger picture, that's a meter-dose inhaler with a spacer that kind of just helps allows the medication to get to the lungs much faster. On the bottom right hand of the screen, we have a nebulizer. So a nebulizer is another way to administer medication during an acute attack. If basically what it does is it just delivers a really high concentrated dose of the rescue inhaler medication. So it goes through a machine, which basically, again, helps to deliver a much higher concentration of the medicine. You also have a picture in the upper right, and that's basically an inhaled corticosteroid that you can see, which usually gets administered via a little inhaler that kind of looks like a little disc. Again, that's for more long-term. Most of the medications delivered that way are for long-term control. So it's not something you would use in the case of an acute attack. An acute attack requires a beta-2 agonist to allow for that immediate bronchodilation, basically to kind of open up the airway, whereas some of your other inhaled medications are for the more long-term control of the inflammatory component that's typically associated with asthma. That takes us into looking at our different conditions that we're going to be looking at in regards to the lungs in the thoracic region. The atelectasis is a collapse of the lung segment's alveoli, and this is going to be a cause typically of some other injury, so this doesn't happen on its own. It's usually either some other disease or some other injury basically causes this to happen. Some of the complications related to this can lead to a pulmonary hypertension, and cor pulmonale, which are other associated conditions that come along with this. These people are also at increased risk for pneumonia. Again, there's a picture illustrating what typically happens. What they're showing here is actually an obstruction of the lungs, causing the collapse of the alveoli. So again, the alveoli is where the exchange of carbon dioxide and oxygen takes place. Again, you commonly will see this in a lot of bedridden patients and/or people that take a severe blow to the thoracic region.